you guys are responsible for as the primary care PA. Okay, so this is not most of the time going to be referred. Okay, so we talked about fever and then a little bit of that meningitis and encephalitis here. So in general, what does a fever do to a child who has an underlying diagnosis of epilepsy? Make you more or less likely to have a seizure?
More.
More likely, so it's going to lower that seizure threshold. Correct. What is the lowest age that you can give a child acetaminophen? No. 2 what? 2 months. 2 months for acetaminophen. What is the lowest age that you can give a child ibuprofen? 6. That one is 6 months. Correct. What is that dose of ibuprofen?
10 to 15?
5 to 10. 5 to 10 what? Yep, correct. Milligrams per kilogram. Good. And then what's that dose of acetaminophen?
10 to 15.
10 to 15 milligrams per kilogram. Yep. Okay, an infant is less than 90 days old. What disease process are you adding acyclovir for when considering empiric treatment for a toxic appearing child with a fever?
Herpes.
HSV, correct. If you see fever in a child with a diffuse petechial rash, what is it until proven otherwise? Meningitis, what type of meningitis? Neisseria meningitis. Yep. Are uncircumcised little boys at lower or higher risk of UTI in the first year?
Higher.
Higher. A deficient in your complement pathway makes you consider what diagnosis? I told you it was a meningitis. What type of meningitis? Yep. Neisseria. It's another Neisseria. So that's a good one to guess. When in doubt for meningitis, guess Neisseria. We've got a lot of those answers are that. What would be the indications to CT scan a child before you do that lumbar puncture?
Intracranial pressure.
Intracranial, increased intracranial pressure. What else? One other thing. There's diffuse signs versus focal signs. Which one are you going to scan? Focal.
Focal.
Focal. Correct. Okay, so we're kind of taking that all the general stuff with fever, and then we moved into meningitis and encephalitis, and we build on that to talk about all the other different types of infectious diseases. Now, this is not going to cover every single thing that a child could have, and this covers a couple of things. Hints of different topics, but also the things that are easily distinguishable, because there are some viruses that look the exact same, and they're some with very distinct patterns. And so these are the distinct patterns that you will be able to pick out from other things. So that's where we're headed for infectious disease today. When we, first of all, have to talk about what goes together. So I said this the other day, is kids are going to come in, number one, in real life, and number two, on the test. These kids are going to come in with fever and a rash, fever and a rash, fever and a rash. And a lot of times your diagnosis is going to be, yes, they do have this viral rash. So part of it is going to be, how do I even word this? How do I code this? So the fancy word to say, they have a skin rash, is to say they have an infectious, most of the time viral, cutaneous, on the skin, exanthem. So they will come in, the parents will say, I think they have a rash. And you're like, they in fact do. And your diagnosis is going to be a viral cutaneous exanthem. Meaning that if there was something on the mucosa, you could also say they had an enanthem too. It's not, so using your medical terminology, exanthems, enanthems. You could use both. So just different ways to diagnose them. So all of these are these classic childhood exanthems that we see. And this came back from the day, the history, you guys know I kind of like some of the nerdy medical history. So back when we didn't have PCR, we didn't have viral testing, they had patterns. And so they would look and see what is the pattern that this child's illness is, and what is the pattern of the rash. And they had a numbering system. So they would call it first disease, second disease, and so forth. The only one that has remained is what? Fifth disease, correct. So that's really the only one, and it came from this old nomenclature where by the patterns they would just name them that. For our purposes here, so when I am testing you, I will not go first, second, third, fourth, fifth, other than fifths, because that one's used. I also will not use rubeola and German measles. So I will go with measles and rubella. So that's how you will get tested. Caveat, I have seen board questions and prep questions use rubeola. So I'm not going to test you with that, but that would be the one I would know that measles and rubeola are the same. So we'll talk through these. So measles, hot topic in life right now. The previous case, the first time that it kind of popped back up was 2019. And they had the Disneyland exposures. Anyone remember Disneyland exposure? We'll talk about why that happened. But there was about 1,200 cases of that, and that was back in 2019. 2024, there was only 58 cases in the whole country. What do you think it was last year? A couple thousand, exactly. 2140 cases, 2144. They had already this year, in January and February, we've had 910. So it's headed straight up. So measles will be one that we went from this used to be something we saw to something that we're all going to get familiar with. Right? Pretty easy. So measles or rubeola. Again, I will use measles. Very, very contagious. It is a stable virus, so the DNA stays pretty stable. And also makes it a great vaccine and makes a great antibody because it stays so stable. So when we started vaccinating, all of a sudden, as long as we got that herd immunity high, it stayed away. The problem is you need about 95% herd immunity. So if even in this room, 2 people weren't vaccinated and measles went through the room, you would see those 2 people probably get that. Very, very highly contagious. I need to update this now because 2024 was just a couple of hundred cases and now we're in the thousands. So. Comes in respiratory and blood and urine. And the thing about this virus is it's a pretty, it's stable, but it's also small. And so it can hang out in the air for a long time. So think about that. If somebody coughs in the air, it stays there. And then think about Disneyland. You're in line and you just walk through someone's cough. You just continue to walk through that. Now you've just given everyone in that line exposure to measles. So that's why these endemic places or places where people are in these small confined areas, especially without that herd immunity, very, very likely to spread. So Disneyland was like the perfect place to spread measles. A bunch of unvaccinated kids standing in a confined space, following each other after they coughed. Perfect place for that. The transplacental antibodies, they stay really stable as well. So mom passes them to the placenta, to the baby, and since they are such stable antibodies, those antibodies stay in place for about 12 months. So it should make sense. That's why we give the vaccine at about 12 months. When those antibodies are waning, that's now time to give a vaccine for that. The 4 phases. I will need you to know the 4 phases. We'll talk about it more on the next slide. But very distinct phases for measles. That incubation stage, then the prodromal, xanthomas, and recovery. Most infectious at the very beginning of that. So you are most infectious before you even know you have this. So that's going to be another contributing factor for a lot of these viruses as to why they are so contagious. Okay, you're going to need to know this one. So, incubation. Now if you said, hey Dr. Klein, what did you have for breakfast this morning? I would say, oh, don't even remember. So if you're now asking a history for this patient to say, hey patient, what did you do a week ago, 2 weeks ago, 12 days ago? Do you remember what you did and who you were exposed to? Because that's the history that you're trying to get. And that's why a lot of times tracing these back is really hard because the incubation period is pretty long. The prodromal period then has the classic thing that you're going to see. So cough, coryza, that runny nose, and conjunctivitis. If you see those 3 together, they are telling you measles. It could be nothing else. At the same time, you get a relatively high fever. And so if we remember back from the fever lecture, typically bacterial fevers spike really high and stay high until you get antibiotics. This acts a little bit more like that. Once the kids start to get sick, it goes high and it stays high for several days. So it's not the ones that typically kind of go up in the 100, 101, 102. Once the kid is sick, goes high, stays high typically. So in that higher fever side. That other thing was those Koplik spots. We're going to talk about those in a little bit because if you ever see those, slam dunk, slam dunk diagnosis. Such an interesting virus because it does very unique things. Most viruses do not do unique things like this. A particular rash, so now you've had 14 days, 2 weeks since they've been exposed from this, and this rash starts at your hairline. How it knows to start at the hairline, I will never understand, but it knows to start right at the hairline and work its way all the way down. When it gets down to the body and into the extremities, that's typically right around when the fever breaks, and then it resolves that same way. It starts to resolve from the top and head down. That's a weird pattern. It's a very distinct pattern. Most of them do not start at the hairline. Most of them resolve in the same pattern that they resolve, they go all the way down and then they resolve backwards. This one resolves like it started. It's a very, very strange pattern. It fades and then desquamates. So when you're studying these, those unique patterns, and then things about them. Do they desquamate? Do they not? Do they itch? Do they not? Are they on the palms and soles? Are they not? Those are going to be how you're going to distinguish these on this block. Your conflict spots, another really, really weird thing that this particular virus does is it creates these little gray sand-like areas, and what's happening is, again, I do not know how this virus particularly knows how to do this, but it has a teeny tiny isolated spot of necrosis right opposite your inferior and posterior molars. Why? Why does it know how to do it right there? At the same time, you get a vast and a very kind of aggressive neovascularization at the same time. So you have this very, very short window where you can see that localized necrosis, like 12 to 24 hours. If you catch that right opposite that molar, you know it's measles, it could be nothing else. No virus does this isolated necrosis right opposed to that back molar. No, nothing else does that. It can be nothing else besides measles if you see that. If you miss it, it doesn't mean it's not measles, it just means you didn't catch it in that 12 to 24 hour period. This is what the rash looks like, or the exanthem looks like. Again, starting in the hairline, going all the way down. It's a macular rash, so it's not going to be raised. And then eventually it will kind of turn a brownish color and desquamate. You can do this clinically. So if they come in with that exact pattern, cough, coryza, conjunctivitis, and then the rash, you can totally diagnose clinically. Or you can do a reverse transcriptase RT-PCR for that. When you're sending your antibodies, remember IgM tells you that the patient has something right now, right meow, okay? That's how you remember that. IgM means right meow. IgG means they had it in the past or they were vaccinated against it. So you can do those IgM for that. And the biggest part of this is, since this was one of the things that basically eradicated, this is a reportable disease to public health. So public health in the military, if you're working active duty or on orders. Public health on the outside, to your local area, if not. So that is a reportable one. So if the lab gets it back, often the lab will do it, and you as the provider as well. Supportive care. So in general, for all of these, they're going to be hydration, keeping them hydrated, keeping them comfortable, handling any symptomatic fever. The other interesting thing about this, so not only does it have a really strange pattern of the rash, not only does it have a really long incubation period, not only does it have those really weird localized areas of necrosis, but it also, particularly the measles virus, basically sucks you dry of vitamin A. So it uses vitamin A in its replication process. And so when, super interesting to me as a history nerd, when WHO teamed up with UNICEF, they were teamed up actually to help prevent blindness. And so they had gone out together in the late 80s to pass out vitamin A to help prevent night blindness, to help make the chemical rhodopsin in the eye. Anyway, not irrelevant. They were passing out vitamin A to help with this night blindness, and all of a sudden they realized that everyone that they were giving vitamin A to wasn't contracting measles. And if they were, it was a very, very low percentage of having any kind of complications, and they had a pretty easy course of measles. So all of a sudden they were like realizing that there was that link between measles and vitamin A. So that is the recommendation, is if somebody has measles, not going to be a preventive strategy, but if somebody has measles, another option you can do to make sure that they are not depleted of vitamin A, because you know that virus is going to take that up to replicate, so they're going to be low in that. Complications with this. This is going to be the same for most of these viruses. More likely to get an otitis, more likely to get a pneumonia, more likely to have CNS complications. If you see a CNS complication from measles, number one, you as a provider have seen measles. Number two, you've seen this long-term measles, so come find me. If you ever see the sclerosing hand encephalitis and you diagnose that 20 years after they had measles, please come find me so I can sound you best PA ever. So the best strategy then is prevention. Rather than giving everyone high doses of vitamin A, where they would be at toxic level doses, best strategy is to vaccinate. So interesting thing about this vaccine. So this is another one of those really weird things. We give it as a live virus. And so we used to say, hey, well, varicella is another live virus. So why don't we just give those at the same time? Let's give them at a year when those antibodies wane. We'll give MMR and V together. MMR-V, it'll be great. And we did that, and we saw that 12-month-olds that we did that to had a rise in febrile seizures. So we were like, well, that's weird. And they don't happen when we give MMR and varicella, even if we give them at the same time. But something about MMR-V increases your febrile seizures. So MMR at that 12-month mark, MMR-V at 4 years old. And you don't see the febrile seizures with that. Remember, it's a live vaccine, so you can't give it if they're immunocompromised, and you can't give this to pregnant patients. Your post-exposure prophylaxis. So this is where we are manipulating physiology. So we said, well, we know that they have this long incubation period, this long prodromal period, so if we know we're exposed, we could go ahead and vaccinate and get that started and help prevent this. So this is one where you can do post-exposure prophylaxis with a measles vaccine if you're within those 72 hours. And it has an immunoglobulin, so options that you could do. Okay, rubella. That was first disease, right? Now we're headed down into rubella. German measles is the other term for that. And what I want you guys to think about for rubella is think measles light. It's a lot like measles, but measles light. And it does some weird things that we're going to talk about, but measles light is a good way to think about this. So when we think about what things we have vaccines for, it's going to be for two reasons. One, we're going to vaccinate against something that's going to be really harmful to the patient. Okay, so we're going to vaccinate against polio so that kids don't get polio and have respiratory compromise, right? There's also some things that we vaccinate against, not because it's bad for the kid, but if the kid gives this to somebody else, it can be devastating. And that is the case for rubella. So rubella, pretty mild to most children, devastating if you get it when you are pregnant. Okay? So we vaccinate children so that other people who are pregnant do not get rubella, so that they then do not get congenital rubella syndrome. It's part of your OB screening, so they'll always see, are you rubella immune? We'll talk about why. So this virus, very similar to the respiratory epithelium. We'll go to the lymph nodes as well. Again, very highly transmittable. It will last the same couple of days, so you see the same pattern, very similar as you do for measles. The problem is, it's very, very, very contagious, particularly in that first trimester of pregnancy. It's likely to cause problems then. Rare to cause problems after all of your organs are formed, but very highly likely to cause problems in that first trimester. You're going to need to know these. So which trimester are things affected by. Okay, so rubella goes with first trimester. So postnatally, now you just have a kid. Let's say you have 3, 4, 5, 6-year-old, however old, a child that gets this pretty similar to most other URI. Really not something to write home about for most kids. Again, that long incubation period. The one difference here is when you think about where that lymphadenopathy is. So if I said somebody has anterior cervical lymphadenopathy, and they have tonsillar exudates, and they don't have a cough, what are you guys thinking? Strep. Great. If I say someone has posterior cervical lymphadenopathy, and they've been sharing drinks and they're an adolescent, you're thinking mono, what virus most likely causing that? EBV, correct. If I said they have posterior and anterior, but suboccipital and postauricular, that's a weird pattern. Right at the base of their skull and behind their ears, that's a very strange pattern of significant lymphadenopathy. That should make you think rubella. The rash is going to be, again, measles-like. So it's still going to start on the face. It's just not going to start at that hairline. So it starts at the top, works its way down. It's just a little bit less prominent. It also has mouth spots, but different than those Koplik spots that are pathognomonic for measles. It's going to have Forsheimer spots. And really, the way to say this is that it looks like petechiae on the palate. So palatal petechiae. The reason that it's not pathognomonic is that palatal petechiae can be seen with a lot of other things. What's the most common thing we see palatal petechiae in? Nice Syrian images. That's a good one. It's not right, but that was smart. You see, You can get it with SJS. What do you see it most commonly with? Strep. So strep pharyngitis. You can see a palatal petechiae. Yep. You can see it with Kawasaki, you can see it with SJS, but commonly we'll see with strep. So that's what it's going to look like. So if you see the picture on the right, it's not necessarily going to be rubella, but in the setting of the right lymphadenopathy, an unvaccinated child, and Forsheimer spots, you're like, that's rubella. It could be nothing else. Same serologic testing. IgM, they're having it right now. IgG again, if they've had it in the past. Another PCR test, and it's also reportable. So very similar. So the same exact pattern for measles is going to happen for rubella. Here's where the difference is. This is crazy to me that this virus particularly does this. So it's happening embryologically when all of the organs are forming. And so it's going to upregulate mitosis in some areas, and it's going to downregulate mitosis in others. And that's a big problem because you're going to see this upregulation in some things and downregulation in others. So you'll often hear the blueberry muffin baby. You're like, well, what am I even looking at? Well, this picture of this baby looks like they have all these little spots or all these little kind of rash-like things. And so we call it a rash, but it's not actually a rash. The upregulation of hematopoiesis happened. So where does normal hematopoiesis happen? Where does your body make blood cells? In the bone marrow, right? It doesn't normally make it in the skin, but it upregulates hematopoiesis, and so you get extramedullary hematopoiesis in the skin, making these little blueberry spots. That's wild. You get this blueberry muffin-looking baby from extramedullary hematopoiesis. You then get downregulation in some of your cranial nerves. So you get the downregulation in some of the temporal bone and your auditory nerves, so you end up with sensory neural hearing loss, deafness. You get a downregulation of mitosis, and you end up with congenital heart disease, most commonly a PDA. And you get upregulation in your lens opacification, so you end up with early infantile cataracts. Remember from block 1, what is that going to look like if you do an eye exam? Leukorrhea, or that white reflex. So this could be a reason that you see an infantile cataract. Leukorrhea, why am I saying that? Leukorrhea, thank you. I saw your face and all of a sudden I was like, oh my gosh, wrong word. Thank you. Thank you for your facial expressions. It helps give real-time feedback when I say things like that. Thank you. And then the problem with this though, so you've upregulated and downregulated all these different things, and then the baby continues to shed this virus for months afterwards. So if they are continuing to have this, they're continuing to shed this, so they really functionally can't go to places like daycare as long as you have somebody who's unvaccinated, because you're going to potentially repeat that cycle. So susceptible contacts. So congenital rubella, wild. The boards love congenital rubella. No specific treatment again for this. It's another one of those preventions. And this would be one of those things that when you're counseling childbearing aged women to make sure that they have immunity to rubella. Because once they're pregnant, well, you've already missed a lot of the first trimester when they're susceptible. And also, oh wait, you actually can't give them that vaccine because it's a live vaccine. So this would be one of those things in preventive counseling to think, your childbearing years, do you have an MMR? Are you up to date on rubella? Do you have titers against rubella? Again, some of that theoretical post-exposure prophylaxis could be done. Given the long incubation period, it's just not as common because most of the time we don't see those severe complications that we do. And we already talked about pregnancy. Okay, so first trimester is the big thing, congenital rubella, and then the different things that you see with congenital rubella. This one's weird to me. Your textbook decided for whatever reason that it wanted to talk about measles and rubella, and it just left out mumps. No mumps in your textbook. So this is one of the places where we pulled out from the Big Nelson's textbook that I know you all lovingly read every night before you go to sleep. So this is from that, if you are wondering. So that in between, so we have measles, rubella, now mumps, self-limiting infection of the parotid glands. And really the way that you need to think about mumps is it attacks any of your secretory organs. So anywhere that can secrete things, mumps is going to be a problem for. Most classically in the carotids. In the saliva, again, you have your prodromal period, so you're infectious before and then a few days after, so it's recommended for that isolation at the beginning. When you're saying secretory places, where else are we talking about? Well, we're talking about the pancreas, that's secreting those pancreatic enzymes. We're talking about the testicles. We're talking about ovaries. Pretty rare for the ovaries. And then CNS, so that's kind of the one outlier here a little bit. When you think about this, you think orchitis, what's really going on with that? Well, the virus can get into those secretory cells, cause a localized necrosis, and that creates that infiltrate and that inflammatory process that actually then stops any of your secretory processes. So you see why little boys, especially post-pubescent boys, that end up with an orchitis that can cause some infertility issues. So that should make sense then, because that's how that virus works. A couple of cohorts ago, they asked, well, what about female infertility? And it can happen, but it's case reportable of the ovaries. So it's from that localized necrosis that they see. But what we typically think about, especially when we're talking about pediatrics, is really prepubescent. So what are you most likely to see there? Well, that's that parotid swelling. So yeah, they're going to come in with a fever. Yeah, they're going to come in with the parotid swelling, but it should be incredibly significant. So this is the picture out of the textbook, that top picture. And if you told me this is a child with mumps or not mumps, I probably would say, okay. It's not particularly drastic to me because I can't see what that child looked like pre-mumps. So they kind of just look like a fluffy child at the top. The bottom picture is a before and after. So this is the same child, the same human, before they have mumps and then active mumps. Jeez. So that's the pronunciation of the swelling and how much it is for a child. So again, you might just think, oh, maybe this is just an obese teenager unless you have a before picture. So if a parent comes in and says, this child's face is swelling, a knee is swelling, a belly is swelling, whatever they're saying is swelling, often ask for a before picture because that actually helps you clinically see how bad is this in relation. Again, your clinical history and physical exam is going to help with this. Again, parotid is going to be often where they have the most issue. Rash is pretty uncommon with this, so it kind of doesn't fit with measles or rubella. It's in the middle there. Same labs that you can do. You can do amylase. You just won't see that it's going to be super specific. It'll be highly sensitive, but not specific for that. Other things can cause parotid issues, much less likely in children. So if you see a child unvaccinated with parotid issues, highly likely that it's going to be mumps. Prognosis is excellent. Again, those fertility problems are what we see, and typically if you're doing those later in life. So if you see on your pants a teenage boy who is unvaccinated, who has parotid issues, they're going to be much more likely to have fertility issues than if you had a, say, 6-year-old. So, the difference. Again, prevention, vaccination. Still a live virus, so you're still not going to vaccinate if they're pregnant or immunocompromised. Okay, fifth disease. So this is the one I need you to know all three names. So I need you to know erythema infectiosum, I need you to know Fifth's disease, and I need you to know parvo B19, the next one. All three get used, all three are used in board questions, all three are fair game. That makes sense? There's three phases of the rash, there's three names for this. 3 and 3. 3 and 3 for Fifth's disease. Erythema infectiosum. Parvo 19. Pretty benign in most kids. Did I say on here? Do you remember what the rash looks like for this?
Slap cheek.
Slap cheek. So that's the first level of that. So kids will come in slap cheek. Not that big of a deal. The problem is this particular virus goes after your red blood cell precursor cells. That's just where the virus goes. Much like the other ones go to secretory cells all over the place. This parvo B19 goes after your baby red blood cells. Totally fine for most people. You shut down the factory for a week, 10 days, in most normal healthy humans, it's totally okay. You have enough, it will be just fine. Well, that's a problem in who? Yeah, if you don't make correct red blood cells and you rely on that factory to keep pumping new ones out, you don't have 7 to 10 days of a backup. So if you have sickle cell, thalassemia, severe iron deficiency, severe anemias, any kind of a hemolytic anemia where you're continually breaking this down, you're going to have problems with parvo. True. Yes. So anything with that myeloid lineage is going to be what you see this. And those people, those kids, they've had these, are going to be then at risk for an aplastic crisis. Right? Their factory is shut down. So now you are in an aplastic crisis state, and if you are a fetus, that is not going to end well for you. If this is 7 to 10 days of that factory being shut off, then you are going to get in a state where you are in, that is incompatible with life. So this could be one of the reasons where you see hydrops fetus in the second trimester. So that's where you have a lot of flow equals grow. All your organs are formed. Now that blood is flowing, taking oxygen, you are growing. So when you have no flow, you have no grow, that's incompatible with life. So parvo, problem in second trimester. Rubella was what trimester? First. Parvo, second. Correct. You see it in the spring. See this with puppies. So if you see a question with puppies, you're probably thinking this as well. We screen for it for transfusions. Again, another long incubation period, pretty mild otherwise. And then you end up with your 3 phases of the rash. The thing that has 3 names also has 3 phases of the rash. So you guys got it for that first section. And then the rest of it is a viral syndrome, so you don't feel good. Anything that you're going to get with a virus, myalgias, cough, coryza, GI, you're going to see those things. So you guys got it. First is the slapped cheek. Slapped cheek, that's the first stage. The other part specifically is it spares the mouth. So you have circumoral power. Not everything will spare this well. Stage 2, then they get a truncal rash, maculopapular, everywhere. Now it is just whole body. So slap cheeks, then it goes everywhere. And then stage 3, it starts with your central clearing. It kind of turns into a darker brown, lacy rash. But this stage, unlike any that we've talked about yet, it's really, really itchy. So these kids in stage 3, very, very itchy, and it desquamates, particularly over places where there is a lot of friction. So if you had kids that are wearing stretchy pants, anywhere where you have that could be a particular area that they are itching and that they have desquamation or desquamation. Anytime where there are necklines, anything like that, anything that's going to cause friction in that skin can cause it to be a particular place where it itches. It is. You're right. I don't know why I had it in my mind. I was like, yeah, this one does. Thanks, guys. Wow, we're just off today. Well, then don't listen to me. The main thing is that don't listen.
Lecture's
I
over.
appreciate you guys. It is itchy. It's very, very itchy. What did I thinking of? That he told me it's right over high air friction. Well, I guess we'll get to it in a little bit, and then you guys can be like, well, she's having a moment. Spares the palms and soles. So it spares the mouth, spares the palms and soles. So spares 3 places, has 3 names, has 3 stages. Okay? I promise I read these. I promise that I read based on what is here. So thank you guys for paying attention and catching me on these things. The big complication, I'm not so worried about the rash. I'm not so worried about those kids who have a viral syndrome. I'm not worried about that. I'm worried about the kids who have issues with an aplastic crisis. So that is why we particularly care about this. So the classic test question is not so much about the rash, it's about, hey, this kid was exposed to this and they had sickle cell, or they have spherocytosis, or they have a thalassemia. Now they come in and they look really, really, really sick. So now these kids look like they're about to have a cardiopulmonary collapse because they are in an aplastic crisis. So if you see somebody in real life or on a test profoundly tachycardic, profoundly pallid, profoundly having some sort of collapse, thinking parvo, do you have something underlying? Reticulocytes. So what are reticulocytes?
Baby blood cells.
Baby red blood cells. So that makes sense. If your factory is shut down, your reticulocyte count is going to be low. Nothing can get pushed out of the factory. Low reticulocyte count, and if your hemoglobin is low, you're not making any noise. Transient though. Pregnant women are at that high risk second trimester event. Passover affects the fetal cell line and fetal hydrops. Big thing, so rubella and parvo. You have those 2 streams. Same diagnosis, so a lot of times this is one where we are not getting a whole bunch of diagnostic studies. If a kid comes in with that slapped cheek or with the history of it, we most of the time are using this clinical diagnosis. And you can do an IgM, you can do a PCR. If you are working in the military and you are diagnosing things by electron microscopy, please let me know what base you're at. There's probably money there, and we could probably do some stuff with that. So, if you're diagnosing things with electron microscopy, well. For the rest of the kids, same symptomatic care. Hydration, antipyretics, and then transfusions if you have highly symptomatic cases, and potentially IVIG if they are very, very, very sick. Kids with that underlying issue. We have about roseola, marching along. So 2 names again, exandum subitum, and this one is so interesting to me because this one, we call it the fever that rashes. Did you guys learn this in ID? Okay. So this is one of the other reasons too why when we talked about don't just, if you get scared, fever, you start treating it with antibiotics. This would be an exact reason why that you shouldn't do that. We'll talk about that. So it's human herpes 6 is your underlying cause. It's also 6th disease if you're trying to pair those up, human herpes 6. And its peak is when kids are about 6 months old. So all the 6s go with roseola. Most of the kids are going to have this by the time they're 2. So this is really something we're seeing in those younger aged kids. This one, again, they get a really fairly high fever in the 103, 104 range. So again, it doesn't fit the typical viral pattern that we see. They get a fever and it's high. So you can imagine parents are coming in because all of a sudden this child has a high fever in the 103, 104 plus and no other symptoms. So you're going down your review, you're doing all the things. Do they have a runny nose? No. Do they have a cough? No. Do they have diarrhea? No. GI upset? No. Do they have anything else? No. Just the fever. It is literally the only thing that they have. You're looking everywhere, and so what people will do is they will try to convince themselves that they have something else. You'll look in an ear and you'll think, well, maybe it's red. Maybe this is an ear infection. And you will convince yourself that you need to treat a fever with an antibiotic. Don't do it. Because Now the fever breaks. Fever on day 3, 4, 5. So right when they're about to come in, so let's say they come in on day 3, and you're like, I don't know what this is. All I have is a fever. I think I'm going to treat it. And you give them amoxicillin. Then the fever breaks on day 4 after they've had 2 doses of amoxicillin. And they get a rash everywhere. What do the parents think is going on? That they are having a rash to amoxicillin. What do they immediately do? When they call you? What do I do for my allergic reaction? What do you as the provider do? You go stop the amoxicillin and you go into the chart and say allergic to amoxicillin. And then the rash goes away, as they do. And now this child is marked with an amoxicillin allergy that they didn't ever have because you misdiagnosed roseola. Okay? So if you don't know what is causing it, don't just throw antibiotics on it. You don't know, and all they have is this fever. Say, let's do a follow-up tomorrow. I want to see you tomorrow, day 4. I want to see you day 5. Because I think that your child's fever is going to break and they're going to come with this whole body rash. And when that happens, you look like a wizard. And then the child doesn't get antibiotics, doesn't have a fake amoxicillin allergy, and then the families literally think you're a wizard. Okay? So instead of just giving amoxicillin, bring them back for day 4 and day 5, wait for that rash, the fever that rashes. The fever that rashes is going to start in the trunk and go out, so the exact same way that you're going to see if they're allergic to amoxicillin, which is why you see this happen over and over. And then it happens. So after the fever breaks, the rash starts, the rest of the viral symptoms will come on if they're going to come on. So it's kind of in reverse of what you normally see. Febrile seizures can happen with this, especially because it's a quick fever and a high, so it makes those come on pretty fast. Already said that. You can get a viral culture. It is not necessary. I think in 12 years I have never gotten a viral culture, but if you're doing electron microscopy for things and you want to do viral cultures, that's the gold standard. Again, supportive care, you can do ganciclovir if they are immunocompromised. Again, I don't think I've ever seen this, that we do this. So that would be very extenuating situations. Most of the time, I see you in clinic, and I just, please, I beg you, as a pediatrician to providers, do not give this kid amoxicillin. For the love of God, don't do it. Where? Top of this? Roseola? Oh, every month. Yeah, you see it happen all the time. If you're seeing kids all the time, you see roseola all the time. Especially because it's not a vaccinated thing that we think, so every kid will get it most of the time. 90% by the time they're 2. Okay, chicken pox. Who here was born after 1995? Wow. Okay, that's incredible. You probably got vaccinated. How many people in this room got chickenpox? Okay, there's some of us. I was at Niagara Falls with my family when I got chickenpox at 8 years old. So in my head, when you go to Niagara Falls, you get chickenpox. Right? So beware, if you go to Niagara Falls, you might get chickenpox. But varicella, right? So we're going to start seeing this flip. A couple of years ago, most people hadn't. They'd all had chickenpox. Now a bunch of the vaccinated. And then we're going to see it flip again with some of the anti-vax. Okay, right? So varicella, chickenpox. Primary, you guys know this, primary chickenpox, secondary zoster or shingles. Those names are going to get used interchangeably on your pants. The dorsal root ganglia. So that's important. That's a particular place that this virus goes back and hides. So the virus goes to xanthum, and then that virus goes and it lays dormant back in the dorsal root ganglia. The thing is, that happens at every different level. So every different level of your spinal nerves, where those are hiding, dorsal root ganglia. So what happens when you get really sick or when you get really stressed? And it pops out of usually one at a time. That's why it's dermatome on one side, based on where it lies dormant and then how it gets re-expressed. Airborne, direct contact again, long incubation, so all the same thing. And the biggest thing and the biggest question that always gets asked to determine is it varicella versus something else are that you have different stages of the lesions all at the same time. The question parents going to ask, or anybody's going to ask, is when can you go back to work? When can you go back to school? Now you have this kid that's itchy. When can they go back to school? So when everything is crusted over. No new lesions are popping up. When everything is crusted over, then the kid can go back to school. Pre-vaccination era, again, 1995, so we saw this big drop-off in this. You see it seasonally, as with most of these things. That prodromal symptoms, so they feel pretty icky. Those first little bit, the younger you are, the better you feel. So the happier kids are the younger ones. Pretty high temperatures again. And then again, spreads in the trunk, goes out, goes everywhere. And you have all the different stages. So some are going to be in the vesicular stage, some are going to be crusted, some are going to be open. If you had them all at the same stage, what do you have? Smallpox. And you should call somebody because there's bioterrorism happening. So you should call somebody from the pediatric clinic if they are all in the same stage. Very good. Right? So all the different stages of the lesion simultaneously. This one, profoundly pruritic. You guys have had that if you remember it. I remember distinctly at Niagara Falls on that ship thing, underneath getting poured on, just scratching, right? Just profoundly pruritic. Non-umbilicated, so what does umbilicated mean? Central little hole. So non-umbilicated, and it's got, I don't know why they always call it the teardrop on a rose petal, right? It's the silliest little name, but it just means it has an erythematous base and it's taut. It looks like it's about to fall off of the rose petal. Cannibular mucous membranes, the fluid will progress over time. So it will start as a taut lesion, it will go into cloudy, then it will rupture, crust over, and heal. I've been continuing to have new ones for about a week. This is another one, I think that we will go from nobody would used to see this to, oh yeah, we all know that's chickenpox and we'll see it again. We'll come back.
I went to the local chickenpox party.
Yeah, the local pox parties. You see, some kids are happy, some are not. The younger you are, again, the happier you are. So the kid on the right side who's just couldn't be happier in life in his little oatmeal bath. The kid on the left, not happy, profoundly pruritic. This is a good example where you have all the different lesions. So you see the erythematous base. So that's the first thing that you're seeing. You're seeing some of them that have clear fluid in them, some of them that have the cloudy fluid, some of them that have ulcerated and opened, and some that are crusting over. You see all of those at the same time on this hand. This poor kid probably has, I don't even know how many lesions, if that's what the hand looks like. And we'll do complications and we'll take a break, or get your laptops or whatever it is. So, the complications. Think about this. If you have a grubby little kid who's scratching all day long, eventually you're going to excoriate that and you're going to give yourself a secondary skin infection. You're going to see this complication as a secondary skin infection is the most common thing that you're going to see. So do you get an impetigo? Do you get a cellulitis? Or I saw this in residency and it was crazy. This kid scratched so hard they gave themselves neck fash and had to have fasciotomies because secondary to chickenpox and varicella. So this can really happen in real life. Other rare things that we want to avoid, a varicella pneumonia. That is a bad pneumonia. You do not want that type of pneumonia. The other one we talked about whenever I lectured last, varicella encephalitis. So the complications are not, they're rarer, but they're not without their issue. And then let's take a break. We'll talk about Reye syndrome when we come back. I don't know how this is happening. Okay, sounds good. We'll take a break, and then we'll restart whenever. So we said most common thing that's going to happen is these kids are going to get really itchy and get secondary skin infections. That should make sense just because they're itchy. Next is going to be the pneumonias. Not good, especially if you're immunocompromised, especially if you have a child with a leukemia or a cancer. Not good. The next thing we think about, you probably all heard at this point, we're not going to give kids aspirin. Well, actually, why? Well, aspirin plus varicella equals Reye syndrome. Right? So it's not aspirin plus anything else, it's aspirin plus varicella. The whole reason that we don't give kids aspirin comes down to varicella. So that's one of your, doesn't happen with other meds, doesn't happen with other viruses. That combination is specifically bad. So we're going to use, if you know they have chickenpox, a non-aspirin antipyretic acetaminophen or ibuprofen. What's your dose of acetaminophen? 10 to 15. What's your dose of ibuprofen? 5 to 10. Good. It's a superficial infection, so most of the time they're not going to scar. So that's always one of the questions that parents will have about chickenpox. Not going to scar. And then the severe ones will get an antiviral. So how do you classify severe? So older children who are unvaccinated. So if you're hitting puberty ranges, so in an adolescent, true adolescent over the age of 12, and unvaccinated, and you get varicella for the first time, that would be an indication to give the antiviral. If you have some underlying chronic illness that affects your functions, this would not be the kid that has a mild asthma that uses inhalers before sports. This would be chronic underlying pulmonary disease that we're talking about here. This one's in the book. I don't love this one, but the short course or intermittent steroids, because that would be any child who's on asthma treatment. So not exactly in line with the updated guidelines. So I'm not going to ask you that specific thing. So just to be aware, but that is in your textbook. And then if they are on long-term, so let's play it there. So that would be something we would give them that antiviral. The chickenpox vaccine, as good as it does not confer 100% immunity. So not all of the vaccinated children are going to be fully immune. And this is to know. So this is why you're always going to see some of those breakthrough. Again, it's a very bad one. Varicella is one that we really, really, really don't want kids with leukemias or underlying immunocompromised kiddos to get. That's when it starts to disseminate. You get the really hard to treat pneumonias, the encephalitis, a lot of those bad secondary complications. Just really don't want those ones. The other one, so immunocompromised kids with leukemias, we really don't want. The other one is neonatal varicella. So this was back from block one of those relative contraindications to breastfeed is if mom has an open case of varicella or zoster on the breast, or if mom has first-time chickenpox. It would be an indication she's delivering within that 1 week range, 5 days before, 2 days after, to avoid any of that direct breastfeeding. If there's an open lesion on the breast, that would be an indication. So if mom has shingles on her back, okay to breastfeed. It's if she has shingles over the breast tissue, you have a direct lesion contact. And we said this, all of the vesicles, so once everything is crusted over, that's when you can go back to school. So negative pressure, since it's transmitted from a respiratory. So the live vaccine and VZIC. Biggest thing I want you to know for varicella is what the rash is going to look like, some of those complications, what medications you wouldn't give these children. The question that always arises is, well, have you ever seen kids with zoster? Right? You don't really think you hear about that. You see it more than you think that you would. So especially because it doesn't confer that 100% immunity, you do end up with a lot of kids that get zoster. Secondarily, you see a lot of teenagers actually, once they finish puberty, you see kids that end up with a zoster that presents just like the adults are going to. So you're thinking, how is this going to present? What is the pain like? How do they typically describe pain of shingles? Stinging. Yep. Stinging or burning. So if somebody comes in and they says the pain it burns. So that's what I see people miss all the time. You'll see people and providers that will not do a full physical exam. Someone will come in and say, my back hurts, it's kind of stinging. They won't lift up to look at the skin, and they'll just give them muscle relaxers and say you have a strained muscle. The whole time it was shingles. So please look at the skin. I've seen that missed too many times. Most of the time this is going to happen in an older population or sicker population, but again, it does happen in kids. We see it particularly in your adolescents. That same germatome pattern. The ones that we're going to treat, we want to prevent that acute neuritis. We said the burning and stinging pain. We don't want it to persist and continue and have a post-traumatic neuralgia. That is what we absolutely want to avoid. Pretty uncommon in kids, so it's not a big risk. So they're at a smaller risk, and then even within those who get it, at a much smaller risk. That's always what we're trying to avoid. It's involved in that facial nerve 7, you end up with Ramsay Hunt syndrome. So There's this whole generation of people that knew that, maybe 10 years younger than me, when, what's his face? The hair. Justin Bieber got it, and everyone knew about Ramsey Hunt for a very short window period of time. If they had chronic pain more than that, about a month, that's when you are worried that it's going to be one of those lifelong things. So there's two things that I always recommend that grandparents get particularly. Pneumococcal for them, but if you're dealing with pediatric patients, I always want grandparents to get their updated TD. I want them to have, or Tdap, I want them to have the pertussis, and I want them to get their zoster vaccine. The two things that grandparents can do to help kiddos and prevent disease would be those two things. So a good one for your mock OSCE on Monday for prevention if they are over the age of 50. Hand, foot, mouth. What causes hand, foot, mouth? Coxsackie. Yes, and for pediatrics, I want you to write this in. Hand, foot, mouth, butt. It's always on the butt. Hand, foot, mouth, butt. Add that together. So Coxsackie, you guys already have that. Oral fecal transmission. Kids are gross. It shouldn't be surprising to anybody. See it on the hands and feet. So this is one of the only ones that we ever see on the actual palm, on the actual soles, and then in the mouth. Are they painful lesions or non-painful lesions? Painful lesions. And a resident friend get this as an adult during residency, and the poor guy, I swear to, could not even move his hands. It hurts so bad. So this hurts the more as you're an adult. The particular thing it hurts in the kids are the lesions in the mouth. If your mouth hurts, what do you not want to do? Eat or drink. You don't drink anything, now you're dehydrated. Now you have a kid who's coming in to the ER or into the inpatient ward because they cannot and will not stay hydrated. There's so much pain. So palms of soles, bottom of feet, can be anywhere in the mouth. So you can see that kind of around the face. And then it's usually associated in the diaper region too, the younger you are. So the younger you are, hand, foot, mouth, butt. Always check that diaper. It can be on the tongue, on the roof of the mouth, on the lips, or anywhere inside the mouth. Supportive care. So the biggest thing is we've got to keep them hydrated. We've got to keep them pain-free. Well, that's going to be a problem if we're giving oral Tylenol or Motrin, right? So we're giving that orally. What else could you do? What are your other options? How else can you give Tylenol? Rectally. Yes, this would be a really good indication for the babies to give a rectal dose of Tylenol. Their mouths hurt. They don't want to drink. They're going to spit this medication back at you. So a dose of rectal Tylenol is particularly effective for right now. The other thing, weird thing that this virus does. So yeah, they were going to have some of these lesions about 10 to 14 days, so a week to 2 weeks. They can go back to school relatively soon. However, what you need to know, and if you're a provider, especially in a small space or post, is that they shed this for several weeks after. So it makes sense that the kid might be fine, but they just gave it to every single person in the daycare. So now every single kid in daycare is going to come back with hand, foot, mouth. You see it. This spreads wildly through daycares, particularly. Yeah. Other thing that happens, very weird of this virus, is after they're all done, the nails will often completely fall off. How many times do you think, if you don't warn a family about that, are you going to get called when their child's fingernails fall out? Every time, right? So if you tell a family with hand, foot, mouth, hey, I know this sounds really weird, but once your kid is better, watch out in a couple of weeks, their fingernails might fall off. If that happens, again, you look like a wizard. You look like you're brilliant. You don't tell the family, and the kid's fingernails and toenails start falling off. You just have a panicked family. So hand, foot, mouth, butt. Tell them about the fingernails falling off and look like a wizard. Scarlet fever. In that old naming convention, which one was this? Wasn't 5th. Wasn't 6.
7.
There's no 7.
8. Not on the list.
2.
Oh.
What is scarlet fever caused by? What kind of strep? Group A strep. Yes, Group A strep. You guys already know the things about it. Okay, so this one is really interesting. I don't know, has anyone ever seen scarlet fever in here? You felt it?
Yeah, it was my son.
Feel like the skin that is normally really soft truly feels like a fine sandpaper. So it looks like a sunburn and feels like sandpaper. It's the best description of how to explain what this is going to feel like. So every time somebody is going to say, hey, well, can you just do this virtually? Can you do these virtual visits? No, I got to feel. Does this feel like sandpaper? Doesn't matter. It's going to determine how I treat this. So sunburn with sandpaper on it. It's going to look, the rest of it is going to look like your strep pharyngitis. And this is going to be the first time you're going to hear me say this 100 times, literally for our next few weeks together. If it is Group A strep, anywhere, low dose amoxicillin. If it's other things, we're going to end up in high dose amoxicillin range. All Group A strep, when in doubt, Group A strep, low dose amoxicillin. When I say what is low dose compared to high dose, low dose is 45 to 50 mg per kg per day. The high dose, when we talk about that, will be 80 to 90. So Group A strep, and I will need you to know those doses because it's going to matter of how we treat things as we go along. Group A strep pharyngitis, scarlet fever. Later on we'll talk about perianal dermatitis. Anytime we have Group A strep, low dose amoxicillin. When we get to vasculitis and we talk about Kawasaki's, this is the one we're going to try to pull apart. Is this scarlet fever or is this Kawasaki disease? I don't need you to worry about Kawasaki right now, but that's going to be one of your things for your differential later. So this kid looks like he's got a sunburn with a little sandpaper on it. Scarlet fever. Get the strawberry tongue. So it first looks like a white strawberry, then the red strawberry. Exaggerated, swollen papilla at the tongue. Oh, took out some of the other stuff. Never mind, took out the Kawasaki stuff. We'll get to that when we get to the vasculitis. Okay, herpes. How do we treat herpes? Acyclovir. Very good. Mucosal surfaces 1 and 2. We've talked about neonatal herpes, so we're blue in the face. So if we miss neonatal herpes and you don't give them IV acyclovir on your tests, I don't know how else to help you. That's all I can do. What you will see, and this is real life and in all the test questions, if they give you an indication where they say there was a fetal scalp electrode, so after the bag of water is broken, there are instances where they're going to try to monitor the baby, and they will literally insert a monitor, a fetal scalp monitor, underneath the skin on the scalp, so that an open area of lesion. Now then, think about if the mom has a vaginal delivery, and they go with that open area right past a lesion. That's a perfect transmission. So if you see fetal scalp electrode in a test question, they're trying to tell you, watch out for herpes. That is what that means every single time. Oh, and that's what that picture is. So at the top, if you're wondering what happens if brand new little baby had a fetal scalp monitor, had herpes come into contact with it. You can see it on the mouth. So labialis, so that would be one thing to determine. Is it just inside the vermilion border, or is it a gingivostomatitis? Does it go outside the vermilion border? So knowing and distinguishing, does it cross over is going to be one of the things diagnostically and how you're going to treat this. The other thing, way back in block 1, we said what would be some of the things that you would screen for on your sports physical. Herpes gladionotorium was another one. You think it's a herpes infection, this would be something you wouldn't clear that wrestler for until it was completely gone and it had some prophylactic treatment. The viral paronychia, so herpes right around the superficial tissue around the nail bed. Think about, why do kids get this all the time? Biting nails and their thumb suckers. So you see this in young kids, particularly, they suck their fingers or suck their thumb. A higher risk of getting this herpetic whitlow or a viral paronychia. You'll hear both be used. Those two things. You can see it when they have oral lesions too. Additional findings would be some bad breath, some cervical lymphadenopathy. None of that's particularly specific, but other things to think about if you're seeing that. It's going to look like herpes, like you learned in ID and in germ. You're just now having different reasons. Smaller kiddo, different reasons, different transmissions that you're seeing. Treating, same thing. Oral acyclovir or Val acyclovir. I personally prefer, if I can, use Val acyclovir. Do any from farm remember the dosing of acyclovir? It's 4 times a day. If you ask a family with kids to do anything 4 times a day, that's a lot of times a day to do it. Valacyclovir, twice a day. So if I can use valacyclovir compared to acyclovir, I will always choose that one. Uncommon for scarring, something we're not looking at, and this is one that I have such a low threshold to put a bajillion referrals. I would much rather, as soon as this pops up, have the family be able to start this prophylactically than have to wait, call me, get a new script, come in, fill it, and it's been several days now. So this is one where I put a whole lot of refills, and I recommend as soon as they use one to call in another refill to always have one on hand. I think this is one of the things that you guys see in every semester. I think pinworms, right? So tell me what you know about pinworms.
Scotch tape test.
Scotch tape test.
Treat the whole family.
At night.
Itchy.
Itchy. Where are they itchy? Where are kids itchy?
Anal pruritus.
Perianal nocturnal neuritis. How do you treat it? Albendazole. Yep. What's your secondary? Mebendazole. Yep. What's your tertiary? Okay, so let's see if we got here. We got Enterobius. Let's see, you guys got that. It's from the eggs, and then they lay it at night. You guys got that. A lot of kids. So in a test question, things to look for. They sleep with their younger sibling, or they were all at a sleepover. Something where kids are sleeping together at night is a test question thing that you would see. I got really, I had a moment where I channeled Major Holzberg. And I was looking at the viral larvae and really into that. I'm not going to ask you about that. I just think it's interesting and a good reminder of kids are really gross, right? So they're going to scratch their behinds and then somehow their hands are everywhere. So you end up, the whole family has this because their little grimy hands, as much as we love them, are absolutely everywhere. Spreading eggs right and left. So you guys got that nocturnal anal pruritus, albendazole, mebendazole, pyrantoprolol. Yep. Wash everything, all of it. Wash it all. Very hot water. You guys got Scotch tape test. Look at that. That wasn't that bad. What do you know about scabies? Oh, you guys were all like.
It's like the wet.
Yeah. We just
the wet burrows.
Yep, it burrows. Yep, it's a mite. Yep. It itches. Yep. How do you treat it? Permethrin. Yep. You guys got it. So it's that mite. It literally burrows in underneath the skin. So there's a mite that is living under your epidermis and then laying eggs and defecating underneath your skin. If you're wondering why is it itchy, that's why. It's just, and it leaves a long effect from that, so often the itching continues even after the mites have been cleared. Again, worse at night. So your biggest question here is, they both have itching at night. Kids are scratching. Is this chicken pox? Do they have lesions? Is this on their behinds? Is this in finger webs? Are they sleeping with people? Do other people around them have this? So that's what the questions are going to ask you. Can you tell apart nighttime itching? These linear lesions, same things, loves to be anywhere where they can crawl in. The difference for this is, what about a baby? So babies get a different distribution. So whereas all of the older kids are going to be in those classic places, in the groins and fingers and anywhere where there's kind of a folding, not the babies. The babies are going to get on the face, scalp, neck. They are not spared from that. So if you see a baby that looks and you're thinking, well, maybe this is atopic dermatitis. We'll have a whole lecture on atopic dermatitis where I will nerd out on you guys. And you put steroids on this. What happens when you put steroids on scabies? What happens at first? It gets better for just a little bit, and then what? And then it skyrockets, yeah. Itching, it's way worse. It comes back with a vengeance. So if you give steroids on it and they come back worse, now you know. In between the fingers, again, watch for that. Watch for sleeping together at night. The whole family has it. You guys already said the permethrin cream. Wash everything again, very, very hot water, as hot as you can get it. Boil things if you need to boil them. And seal things in a plastic bag for 7 days. If it's sealed, you're going to kill those mites. Biggest thing then afterwards is people are going to say, I still itch. And they're going to want to think the treatment didn't work. So, how do you know? Are you getting new lesions or have the lesions stopped? I expect them to have a hypersensitivity reaction for up to 2 weeks after you've treated them. But are they getting new lesions, yes or no? That is your distinguishing factor. If they're not getting any new lesions, it's a hypersensitivity reaction. If they are getting new lesions, it's potential treatment failure. So that's your distinguishing characteristic. Are you getting new lesions or are you not? Lice. What do you know about lice? Surrounding hair shaft. Yep. School kids. Several different types. Yep. Treat it with permethrin, a lot of the same things. So yep, you can get it anywhere where there's a hair follicle. And the most commonly capitis, which you can see anywhere. They can't fly, they can't jump. So this is what's particularly interesting about lice. It has to have direct contact, which is why school children particularly, they like to share brushes, combs, braid hair. But how are we seeing it transmit in older people now and older teenagers? Hats? Headphones, potentially. Interesting study that came out where it was from the selfie. People were putting their heads together for a selfie, and that was contact, and they were getting lice from selfies. Okay? So just make sure you know who you're taking selfies with. Look at all your old pictures of selfies. But that's that direct contact that you're looking for. You guys said it most common in the scalp. It's translucent. So really when you're looking at it, as opposed to a seborrheic dermatitis that has a white flaking, this is translucent. Seborrheic dermatitis, if you flick the hair shaft, it should fall off. The knit in this case will not. It adheres to the hair shaft. So it must be completely scraped off. So a little bit different. So if you see a test question where it can't be scraped off versus it is attached to the hair follicle, it's asking seborrheic dermatitis versus lice. That is also one of the reasons, if you're thinking back to your CS days, where CS1 and CS2, and you're looking through the hair and you're like, why am I doing this? The actual physical exam skill is you're supposed to pull up the hair, look at the back of the neck and behind the ears. You're looking for are there nits, are there lice? Because that's typically where they will hide, way back in the neck. Pictures the translucent that you're seeing attached to the hair shaft and then right at the base of the neck. Things that you're seeing. You will be surprised as a provider how many times you will be doing an exam for something and you will be looking at the person and realizing that's lice. You will be shocked and you will please tell them, right? Don't just let them go with their lisinopril and their lice, right? Treat their lice and give them lisinopril.
You only get one complaint.
No, you can have treat their lice. You guys got it, permethrin. A lot of times they've already done that, so they've done the OTC and they are here for you. So I need you to know, first of all, your OTC products, because that's going to be first line. Have they tried that? Have they done a full treatment of that? And then secondary, when they come back, because there's a lot of resistance, then malathion and ivermectin. So I need you to know all three of those treatments, because depending where they are in the process, you're going to have to use both of those. I always start with the OTC, because if there's not a resistance, great, easier. Malathion and ivermectin can be a little bit more expensive, but to have all of those. Same thing, get rid of it. This is where I disagree with your textbook. So I will tell you this, your textbook says to put it in a sealed bag and use their combs and brushes with rubbing alcohol for 1 hour and okay to reuse. That is not what I tell my patients. I throw the brushes and combs away and we just start all over. So, up to you how you practice. That's what I do compared to your textbook. Up to you. Okay, what does the rash look like for measles? Where does it start?
Scalp.
Hairline, and then what does it do?
Works its way
It goes
down.
down. How does it recede?
From the
Same way.
hairline.
Yep. What is rubella?
Baby measles.
Where does it start? Yep, rubella or measles light. Starts base and neck, works its way down. Correct. How does varicella start?
Everywhere.
Trunk and out. Correct. Who's at the highest risk for parvo? 2 sets of people I really need you to remember.
Second trimester.
Not dogs. What humans? Yep, so kids that have some progenitor red blood cell line issue. And who else?
Second trimester.
Pregnant. What trimester?
Second trimester.
Second trimester pregnant women. Who's at risk for first trimester pregnant?
Rubella.
What are you at risk for particularly?
Rubella.
First. Yeah, rubella. Wow, I just said. Little harder. When is a patient not infectious for varicella anymore?
Everything scabs over.
And everything's crusted over. Correct. How do you treat lice? What's first line?
Permethrin.
Permethrin. Second line? Halcyon or ivermectin. And think about your selfies. Don't itch too much. Hopefully that wasn't too painful. Think we're good? We're still kind of under. They're all yours. See you guys tomorrow, and we will pick it up with ENT.